Good afternoon. This is Jeffrey Sher, Dr. Sher, doing my bi-weekly live feed webinar that I'm so eager to continue doing. And we've had such a wonderful response. And that's thanks to all of you. Obviously, there are lots of questions, and I want to get through as many of them as I can. And we're going to spend at least an hour together. There have already been a few questions that have come through, so I'll hop into those real fast. But I want to just mention that if any of you are interested in getting copies of my new book, which I wrote with my partner, Dr. Drew Tortoriello, the medical director at Sher Fertility Solutions in New York, he and I wrote the one book together. It's about 300 pages long. It's got a lot of information. It's very up to date. It'll be out in the bookstores in a couple of months. But right now, it's available as a downloadable live feed, as a live downloadable ebook, which will be sent to any of you that comment below. Comment the word Sher below in the video, in the most recent video. There's a second book I'll send you, also free as a downloadable ebook. It's on the immunology of failed IVF and repeated IVF failure. I'm one of the pioneers in that field, and I have written this book, which is only about 50 pages long, but it's going to give you more information than you'll get in most other places. So I urge you to please comment the word Sher on the most recent video, and we will be happy to send you the ebooks by return. So let's get going. So Josh, tell me, what do we have as questions so far?
All right, our first question: if you take Dynogest 2 milligrams with stage 3 endometriosis, is there a need of us using 2 luproloid
acid
in IVF with donor egg?
Is this for a woman with endometriosis?
I believe so, yes.
Okay. Well, the question is, do you take these steroids, and do you use Lupron in women undergoing embryo transfer in frozen embryo transfer cycles? And the answer is no, you don't need either. I know that people do administer Lupron and Dynogest to women with endometriosis, but that's mainly to alleviate symptoms or as a precursor for surgery being done for the endometriosis. But in cases of reproduction, in my opinion, these drugs don't really have much of a place. In fact, especially when you're doing frozen transfers and you're not trying to alter the hormonal environment in favor of the woman to get the best possible eggs, certainly using these drugs is really of no benefit in my opinion.
Okay. All right, I have another one. I am 28 with diminished ovarian reserve. I got 6 eggs, 4 mature, 3 fertilized, all arrested on day 5. Any advice for an attempt number 2?
Okay, that is a question from a lady who has who's 28 years of age, been through IVF with diminished ovarian reserve, which means she's got a low AMH, under 1.5 certainly, and she got 6 eggs, and none of the eggs propagated viable embryos that reached blastocysts. They all stopped and arrested in development. Now here's some very, very important information to understand. A woman's born with all the eggs she's ever going to have, and she uses them up progressively. At the age of 28, regardless of her ovarian reserve, the eggs in her ovaries, and there usually are much fewer left if there's diminished reserve, those eggs that she's got have got about a 2 in 3 or 3 in 4 chance of being normal. When you get to 40, only 1 in 5 or 6 are normal. And when you get to 45, only 1 in about 25 are normal, and upon fertilization will propagate embryos that have a normal chromosomal makeup and are competent to make a viable, healthy pregnancy. In other words, they are euploid. They have all 46 chromosomes. The egg is the most important determinant of this. So clearly at the age of 28, you'd expect that to happen, except that when there's diminished reserve, there's an altered ovarian environment hormonally. And that leads to a much greater likelihood that the eggs during their development, during the stimulation, in the cycle of stimulation, will go off the rails and will not develop normally. And if they don't develop normally, when you then trigger with HCG to mature the eggs and get them ready to come out in a condition that makes them likely to propagate viable embryos, that is dramatically reduced. So you may have 6 eggs, and you should have at least 4 of them being normal eggs, being able to produce 2 or 3 at least chromosomally normal embryos. But that's far less likely to occur in women with diminished reserve. Why? Because the protocol used for ovarian stimulation is usually a recipe approach, a one-size-fits-all approach. I can't tell you how important it is that the protocol for ovarian stimulation be individualized in such cases. And I think I can help you, the lady that asked this question, but I urge you to maybe email my assistant Patty at concierge, CONCIERGE, at sherivf.com, and ask to set up a online consultation with me so we can discuss this in detail, and I can provide you with details about the type of protocol you need to get a better result. I think I can help you because of your age and you are still producing eggs. And if we stimulate you optimally, we should still be able to get viable embryos. Once we get embryos that are chromosomally normal, and this primarily stems from the egg, not the sperm, we will end up getting embryos, each of which should have a better than a 50-50 chance of giving you a viable pregnancy. So call Patty and set that up.
All right, we have some questions on the TikTok here. We have someone who said, I've had 5 miscarriages in between my 2 daughters. I'm scared to try for a baby. What should she do?
Women that have had repeated miscarriages have got what we call recurrent pregnancy loss. And while most miscarriages are due to something being wrong with the egg and sperm, the embryo, being abnormal chromosomally, being aneuploid, or having a genetic or metabolic defect, that is usually for all miscarriages taken together. We call them sporadic miscarriages, where the woman can miscarry, then have a couple of pregnancies, and then miscarry again. And if you count them all together, 80% plus are due to chromosomal abnormalities. But it's terribly important to understand that when you miscarry repeatedly, that's the least likely cause. In those cases, the commonest cause is a failed implantation. In other words, it's not the seed, the embryo, but the soil, the uterus, that is defective and not receptive to the embryo. There are 3 major causes for failed or dysfunctional implantation. One of these is if the lining of the uterus is too thin. The other one is if there are irregularities on the inner surface of the uterine cavity, such that there are polyps or fibroid tumors growing into the cavity, making it irregular and irritating it, and rejecting the embryo as a chemical pregnancy or miscarriage. And the other one is if there is an immunologic problem. And these immunologic problems can cause failure to miscarry. This is something that's often overlooked. Again, comment the word Sher in the video below, and the most recent video, and I will send you copies of my books, one of them on repeated miscarriages, and the other one on IVF in general, where all of these subjects are discussed.
All right, we have another TikTok question, and we'll get to Nadia on Instagram here. So we have, hi, I am for DPT, any advice?
On what?
I am for DPT, any advice? I'm not sure what the acronym for DPT.
Could you restate that question, please? Yeah, what do you mean by DPT? You're talking, I really don't understand what you're saying.
That's okay. We'll go to the next one and wait for them to comment. They've commented it a few times. We'll go over here. Can you please explain your approach to management of SCH when they get bigger on us US follow-ups?
Okay. SCH is an abbreviation for subchorionic hematoma or hemorrhage. And that occurs when some blood collects behind the embryo that's trying to attach. And that blood can either expand and cause the entire embryo to separate and you lose the pregnancy, or it can be partial and then be sustained and then absorbed slowly over time. There's no way of knowing which way it's going to go. Obviously, the larger the initial subchorionic hemorrhage, the bigger the prejudice. But you've got to watch it. So the woman has to go straight to bed, relax, get off her feet, de-stress, definitely not use any alcohol or tobacco, and try to relax, and so that she can be followed up by regular visits to the doctor's office where pregnancy tests and serial ultrasounds can be performed to confirm that the pregnancy is growing and getting along normally. And it can also be to measure the size of the hematoma. Now, very often, and I've had many patients like this, these hematomas grow, but then they stop. In the first trimester, they stop growing and they slowly absorb then without prejudice over the next ensuing weeks. If you want to know more about this and other causes of miscarriage, comment the word Sher below at the most recent video that I've done, and we'll send you copies of books that I've written. They'll come to you free of charge as downloadable ebooks, and you'll be able to understand a lot of this much better.
Okay, that person commented again. They said, I am 4 days post-transfer. Any advice? That's what they meant by their acronym. 4 days post-transfer.
Post-regular transfer,
yeah.
I'm assuming. Well, 4 days post-transfer, you have to wait about another 5 or 6 days to get your first pregnancy done. And then you'll know if there's a positive blood HCG, human chorionic gonadotropin level. If there is, then you will retest yourself again every 2 days for a few times. The level should double every 2 days in the early part of pregnancy. If they don't, you've got to be on the lookout for other problems, impending miscarriage or a chemical pregnancy, and sometimes, although rarely, even a pregnancy in the tube. But at this stage, the most important thing is to relax, don't stress out. Continue normal activities. I would avoid sexual penetration at this stage and wouldn't be taking any drugs or alcohol or tobacco, and rest up as much as you can. You've got a few more days to wait before you'll get an answer.
Okay, we got 2 simple ones here I think you can answer. One of them is from Faz. They ask, does aspirin help you stay pregnant?
The use of aspirin in pregnancy is something that used to be a fad. In fact, I plead guilty. I was the one that first introduced and suggested the use of aspirin 25 years ago, because we thought it would thin the blood and stop blood clots forming in the uterus behind the developing embryo and prevent miscarriages, especially if you suspected an immunologic problem where the blood clotting mechanism is increased. But it doesn't. Aspirin doesn't help. And a few years later, I had to retract my position and literally apologize for the misrepresentation. There may be 1 or 2 cases where aspirin may be useful, but it's not useful as a general tool. I would recommend against using aspirin routinely in IVF.
Okay, we have another one they've asked a couple times. Hi, do you believe in the, sorry I might butcher this last name, but Shelt's method? Shetttles method.
I don't know what that is.
The Shelt's method.
Please describe what you're talking about, because I don't know the method you're talking about.
All right, we got a lot of comments coming in. We will try to answer everybody here. We have multiple lives going. All right, we're going to go to Instagram really quick and answer this girl. She's been waiting for a minute. I have a balanced translocation, and I have had 2 ER with no euploids. I have an AMH of 3.5. My new doctor recommends that we try a lower stim rather than high. And for the 3rd round, what are your thoughts?
Okay, firstly, an AMH of 3.5 nanograms per milliliter is good. Means you've got lots of eggs. And a balanced translocation depends upon which chromosomes are involved. What that means is that there's part of one chromosome's material patched onto another one, but it's balanced. And if there's a balanced translocation in you, then it's important to bear in mind that you can still have a baby. You can still have a baby, but the balanced translocation may become unbalanced at the point of getting a fertilization and a pregnancy occur. So when you are pregnant, it's important to follow up very carefully on what's going on with the pregnancy. Prior to pregnancy, if you're concerned that the embryo itself may have an unbalanced translocation, if you have a balanced translocation and the embryo turns out that it doesn't have an unbalanced translocation, then you're still okay. The baby could also be born with a balanced translocation but wouldn't be in jeopardy. So it's important you can check the embryo by doing PGTA to make sure that there is no unbalanced translocation that has resulted from the balanced translocation of your eggs affecting the embryo in an unbalanced way. With an unbalanced way, that means that there's some chromosomal material that is attached, but it's not balanced by another piece attached to the corresponding chromosome, and as a consequence, it causes problems. Unbalanced chromosomal translocations are very rare causes of miscarriage, but they can. About 1 in 200 times a miscarriage can be due to that. And what can you do to avoid it? You can do PGTA. You can go through IVF, get the embryo, and then test the embryo to see that there's no unbalanced translocation in the embryo. And you can also take genetic counseling once you know exactly where the balanced translocation is present.
All right, we have a lot of people on TikTok right now. We have 100 people in and a lot of comments coming through. So we're going to try to get to each one. Bear with us. I have another message here. It says, how can I stop a miscarriage? Please help me. What are some things she can do to prevent a miscarriage?
Well, you've got to find out why you're miscarrying. Most miscarriages are sporadic. That means they occur without announcement, unrelated to an underlying cause, except that in most cases, the embryo is chromosomally abnormal because there was something wrong, usually with the egg that's chromosomally abnormal. And in those cases, there's nothing you can do to prevent it, except when you get to embryos, you can basically do PGTA, pre-implantation genetic testing, for aneuploidy, for irregular chromosomal makeup on the embryo, and only transfer those embryos that are chromosomally normal. If you miscarry repeatedly in a row, over and over, then the common cause of miscarriage is not a chromosomal abnormality in the embryo, but rather more likely to be something wrong with the uterine lining, make it difficult for the embryo to attach properly. And in that situation, there are causes of that: a thin uterine lining, an irregular uterine cavity, or an immunologic cause are responsible for most. Those have to be looked for, carefully evaluated, and by addressing those, you can reduce the risk of it recurring. If you want to know more about this particular topic, I urge you to comment the word Sher in the most recent video, and we'll send you a copy of 2 books. The one book is on miscarriages and the causes and how we deal with it, and this addresses that problem as well.
We have someone on Instagram. They said, so thankful for Dr. Sher for my 2 girls. Her name is Meg. I don't know if you recall a Meg. I don't have a last name at the moment.
Thank you, Meg. It's my pleasure. It's what I do this for.
I have another one on Instagram. It says, can an abnormal embryo be transferred?
It depends what you mean by abnormal. Sure, you can transfer an abnormal embryo. Usually, abnormal means that it's chromosomally abnormal. In those cases, if there's an aneuploidy, irregular chromosomal makeup, the embryo will usually be lost. But there is a form of aneuploidy where only some of the cells in the embryo are abnormal, but the others are normal. In those cases, we refer to it as being a mosaic. And such mosaically aneuploid embryos can resurrect themselves once put in the uterus and still result in a healthy birth.
She has a follow-up comment here. It says, is karyotype testing recommended if I've had 2 normal children?
The answer to that question is simple. Is karyotypic evaluation, in other words, PGTA, advisable if I've had 2 normal children? It depends upon your age, and it depends upon whether you had any other irregular events occur, like miscarriages in between, or whether you failed IVF since the second baby was born. But if you're over the age of 39, I would do PGTA, because as you get older, there's a greater chance that through wear and tear of eggs that have been in your ovaries all your life, the egg will be chromosomally abnormal. And if it is, it's an abnormal egg that leads to an aneuploid or incompetent embryo.
All right, we'll do another Instagram one. If we don't get to your comment, guys, please go comment on the most recent video, and we will make it into its own video. There's a lot of people commenting between all platforms here that we're live on. So go ahead, if you haven't had your question answered in a minute here, comment it, and we can make it into its own individual video. All right, so we have another one on Instagram here. I've had a balanced translocation, and I've had... Oh, we already answered that one, sorry. Let me go down. let's see. Let's go to TikTok here. We've got a bunch, Dr. Sher.
Please go ahead. We'll just do the best we can. Please let your questions keep coming. And for those of you that don't get your questions answered, I will always be happy to answer your questions if you text to Patty and if you email her, she will give me those questions. All you have to do is email the question to Patty, and her email address is concierge, CONCIERGE, @sherivf.com.
Okay. Can you tell me how Omnitrope helps FET?
Omnitrope is known as human growth hormone. Now, human growth hormone is believed to augment mitochondrial activity in the egg, and so gives an egg a better chance of going through the stimulation process without being compromised. It has no place when it comes to FET. Omnitrope is for the stimulation cycle, not for the FET or the transfer cycle.
It says, Hi, I have previous live birth 3 years ago, naturally conceived easily. I just had my 9-week MMC. There's no question of that at the moment.
Okay.
I'm going down. Any tips for third round? Second failed. All 6 embryos failed after a successful first round of IVF pregnancy.
Okay. This lady is stating that she had a successful IVF pregnancy and after that failed repeatedly. Of course, there are things you can do, but you can't do anything unless you identify, quantify, and typify the problem. Let me give you a very basic, simple concept. If you understand this, it'll answer so many questions that haven't come out today, but there's so many questions will be answered. Your egg is the most important determinant of whether the embryo, the fertilized egg, is going to be chromosomally, genetically normal. So it's important to know that we view the embryo, the fertilized egg, as the seed. The uterus that you put the embryo in for it, or where it reaches in nature to be attached and grow, is effectively the soil. The factors and the variables that affect the competency of the seed, the embryo, and those that affect the receptivity of the soil to the embryo are the factors that will determine success or failure. And when you do IVF, it's terribly important to look at all the variables that can affect all of those parameters and then hone in on correcting those that are defective. When it comes to the egg, age and ovarian reserve are very important. There's not much we can do about that. But you can compromise the development of the egg during stimulation if you don't use an individualized strategic protocol, and that's even more important in older women and women who've got diminished reserve. So that is the most important consideration. There's how to fashion an individualized protocol to optimize egg development during stimulation. For the soil, it is the receptivity of the soil affected by the thickness of the uterine lining at the time that you get your HCG trigger or start progesterone for a frozen transfer. And the regularity of the inside of the uterus is going to be smooth. If there are little growths, polyps, or scar tissue into the inside of the uterus, it'll make the uterine lining irritated and reject the embryo. And so you've got to look at that before you do an embryo transfer by doing either a hysteroscopy or a saline ultrasound, not an HSG or a dye X-ray. And the third is immunologic. Immunologic factors are the most overlooked and ignored cause of failed implantation. Now, mostly when you fail to conceive, it is because there's something wrong with the embryo, the seed. So you hone in and focus on designing an optimal cycle of stimulation, protocol of stimulation. And then in 20 to 25% of cases, it's the soil that's not receptive to the seed. And there you hone in on how to improve the thickness of the lining, how to clean out any irregularities in the uterine cavity, and how to treat an immunologic deficit, something I was part of the actual pioneer work in. And this thin book that I'm sending to you, or that you can get as a free downloadable ebook, will explain that. Remember, You can't plant a good seed in a bad soil, and you can't put a bad seed in a good soil. That's the most important message I can give you today. If you want to learn more about this, I urge you to comment the word Sher on the most recent video that I've done, and we will be more than happy to send you copies of 2 books I've written. I spoke about them earlier on. We'll talk about them later again. They'll come to you as free downloadable ebooks, and you can read them. They'll be very helpful to you.
Okay, I have another one here. We have a lot of questions come in. We are trying to answer as many as we can. If we don't get answered today, please go comment it on the most recent video, and we will make it into its own individual video. All right, I have one here. It says, would you recommend Lovenox with a Sorry, I'm going to butcher that word.
Homozygotic thrombophilia, probably MTHFR.
No, this is the word right here. It's
homocystinuria. That is a situation where we have got what we call MTHFR mutation. And when you've got homocystinuria, it depends whether the MTHFR is due to a single gene defect or a double gene defect. The one is called heterozygous and the latter is called homozygous. The homozygous variety does require treatment with Lovenox, starting at the beginning of the cycle all the way through to the 10th week of pregnancy, and maybe even all the way through pregnancy in certain cases. If it's heterozygous, only one mutation, then treatment with folic acid or a derivative thereof will usually suffice over the same period of time. If you have more questions about this or you want to know more, get a copy of my book by commenting the word Sher at the most recent video, and we'll send you the thick 300-page copy of my book, which is written by myself and my partner, Dr. Drew Tortoriello. There's a whole chapter on thrombophilia, on this particular problem in that, and there's also a big chapter on the immunology of infertility.
Okay, this is a more personal question I have here. I am 12 weeks pregnant. Can I stop worrying about miscarriages now, or should I continue?
After you pass the 12th week, the chance of miscarriage dramatically reduces. Most miscarriages occur in the first 12 weeks, and most, in fact, in the first 6 to 8 weeks. So if you get to the 12th week, you still got a good heartbeat, you haven't had any problems, you're probably heading into a smooth stretch of water, and things should go well, and I pray for you that it does.
Please tell me, I'm going to butcher this word too, it's an adhesion. Right there.
Perifimbrial adhesion. Okay. This lady states that she's got perifimbrial adhesions. The fimbria are the finger-like projections at the end of the fallopian tubes that the tubes project off the uterus and they hang over the ovaries like shower heads. If there are adhesions around it, it means it's likely you had previous pelvic infection. Could also have occurred as a consequence of endometriosis, but most commonly it's after infection that this occurs. And the problem with this is that even if you remove those adhesions, it doesn't give you any assurance that the tube is normal inside, because for the infection to get to the end of the tube and cause adhesions, it's got to pass through the tube, and it can damage the very sophisticated lining of the inside of the tube and compromise the passage of the egg and the sperm and the embryo. So if you've got perifimbrial adhesions, bear in mind that it could be innocuous, but in most cases it points towards previous pelvic inflammatory disease, and if the inside of the tube has been damaged, you probably need IVF. If it has not been damaged, then you are probably lucky and can still go forward. There are tests you can do to find out which it is, and it's important that you do those.
All right, I'm going to read another one here. I'm 39. I had my first baby at 36. Healthy pregnancy and a healthy baby. Now diagnosed with low AMH. Can I still have a successful pregnancy with low AMH?
Yes, at 39, you can certainly have a successful IVF pregnancy. If your AMH is low, you need IVF because time is running out and you can't waste it on doing things that are unlikely to work. At 39, things are moving downhill rapidly with regard to egg quality. Not only is ovarian reserve declining, but quality of eggs are declining at a rapid rate too. And all of this prejudices your chance of getting pregnant. So it's important to individualize the approach to ovarian stimulation, as I mentioned earlier on. Choose a protocol that fits your needs. That's the most important of all. It's not just a one-size-fits-all recipe. That's the commonest recipe for failure. You need to use individualized protocols, and you need to look again to make sure nothing else is developed to compromise attachment of the embryo, implantation. And those are the things I've spoken about just now, and they need to be looked for. The regularity of the cavity of the uterus as determined by hysteroscopy or saline ultrasound, the thickness of the uterine lining as determined by ultrasound measurement of that thickness at the time of normal ovulation or at the time you get an HCG trigger, and immunologic factors which are less likely to be a cause but could still be a cause and need to be looked at. Remember that concept: embryo the seed, uterus the soil, and you can't plant a good seed in a bad soil or vice versa. If you want to know more about this, comment the word Sher. We'll send you copies of 2 books that I've written. The one book is a thick operational book on IVF, 300 pages long, to be coming out the bookstores in a couple of months. But in the meanwhile, you can get a free downloadable ebook from me by simply commenting the word Sher at the most recent video that I've done, and we will send it to you. You'll also get the other book. It's a thin book on the immunology that leads to failed attachment, failed IVF attempts, and immunology that can lead to repeated miscarriages.
Okay, I have another one here, and TikTok is blowing up with questions, so I'm trying to get to each one. If we don't get to your question, please comment on the most recent video, and we will turn it into its own video on our feed. Is IVF a good idea to do after I've had a ectopic pregnancy?
Not only is IVF a good idea after ectopic pregnancy, but it's the best idea, because ectopic pregnancies usually occur because the embryo gets stuck in the fallopian tube and can't make its way back into the uterus to attach. And that is usually because the tube has been damaged inside, the commonest cause of which is previous pelvic inflammatory disease due to chlamydia or gonorrhea. There are others as well, but those are the commonest. And once you've had one ectopic, if you get pregnant again on your own, the chance of another ectopic is about 1 in 5. The normal incidence of ectopic pregnancy is about 1 in 150, or 1 in 100 to a 1 in 150. But if you've had a previous ectopic, the other tube is definitely also affected, because pelvic inflammatory disease, if it affects the tubes, always affects both tubes. It's never going to affect one tube. So if one tube has been affected by ectopic, you know the other one is vulnerable as well. And if you don't have an ectopic, you may not get pregnant because of damage and obstruction in the tubes anyway.
Okay, let me go to another question. Do I need to do another hysteroscopy after IVF birth with a natural birth? And a natural birth?
No, I wouldn't, unless you're planning to do another IVF. If you are, it's a good idea to do a hysteroscopy or a saline ultrasound. The latter is far less invasive. It's a T-break procedure. It is virtually free of pain if done correctly, and it's just as good. So I would strongly recommend that if you're going to do IVF and it's going to be done, and you haven't done a hysteroscopy or saline ultrasound in the preceding year or year and a half, that you do one. In our practice, it's usually not necessary, because we will do the saline sonogram at the actual egg retrieval when the patient's asleep, and we will do it free of charge. And that means that we can get all the information ready for when we do the transfer a month or 2 later during the cycle of stimulation.
All right, we got another one.
Keep them coming.
Yeah, we have a time. I'm just trying to find another one here. Does PCOS cause ectopic pregnancy?
Question: does PCOS cause ectopic pregnancy? The answer is no. It doesn't increase the risk of ectopic pregnancy.
Okay, we answered those ones. Do you have recommendations on what to do 3 months out from a second egg freezing at 36?
That's a difficult question. It's not phrased as it should be, but if you're saying 3 months after doing what? She had a frozen embryo transfer.
Any recommendations on what to do 3 months out from a second egg freezing at 36 years old?
Okay. After a second egg freezing at 36 years of age, 3 months out, you really, this is the time to thaw those eggs, make embryos, and if you are 36 years of age and you haven't had problems getting pregnant before, then there's, in my opinion, no need or prerogative to do PGTA. But you could if you want to know that the embryo is normal, and if you want to know whether it's a male or female.
IVF on here. What are my chances with IVF on normal cycle after 2 miscarriages?
I would definitely advise against natural cycle IVF after 2 miscarriages. If you've had 2 miscarriages in a row, that virtually classifies as recurrent pregnancy loss. And as I told you, one of the commonest causes of those relates to something wrong with attachment of the embryo to the uterus, the common causes being thin uterine lining, irregular uterine cavity, or an immunologic problem. And these need to be carefully evaluated. Doing a natural cycle IVF is, in my opinion, a big mistake in someone who's got these kinds of problems. I would also want to, if you were doing IVF, check and see that the embryo is chromosomally normal, because that's another cause of miscarriage, although it doesn't usually cause repeated miscarriages. It causes sporadic single miscarriages. But if you get the embryo, you can do PGTA to make sure it's normal. Check to make sure all of the factors that can affect the attachment of the embryo to the uterine lining are in check and address them before doing the transfer. And if you do it correctly and you put a chromosomally normal, competent embryo into a uterus that is free of the factors that cause implantation failure, your chance of having a successful pregnancy should be 50% or better. But you need to evaluate it carefully before you proceed. I strongly recommend that you contact Patty, calling my assistant Patty, or emailing her rather at concierge, concierge, at sherivf.com, concierge@sherivf.com. Ask her to set you up with a time when you and I can talk so we can discuss these factors. And this goes for anybody else who wants to have my input. We'll have an online consultation. I'll be able to address your issues in detail and offer you appropriate advice.
Okay, we have a lot of questions coming in. If we don't get to your question today, please comment it on the most recent video, and we will make it its own video or answer you through DM. I have another one here that says, I had early miscarriage on the 21st, got my period, and now I have my IH is going up already. I am TTC. Any advice?
Can you repeat that again?
I had an early miscarriage on the 21st, got my period, and now my IH is going up already. I am TTC.
I don't know what she means by IH.
I think it might be a typo. Not sure.
You mean AMH?
It could be AMH that got the typo.
All right. I think that you should give yourself a 1 month break, a full cycle where you do nothing but allow your ovaries to rest, and then come back the next cycle and try again. Early miscarriages are very common. 10 to 12% of all pregnancies end up in miscarriage. Usually they're very early. So in most cases, it's just nature getting rid of an embryo that isn't normal to avoid a catastrophe for the baby and for the mother. So I don't think you should take that as a very serious negative sign.
Okay, this is a business question, and we don't have to answer this one, but clinic is charging me a high amount for canceled transfers that were out of my control. Is that normal?
I really don't feel comfortable answering that question. If transfers are cancelled and it's because there's a medical reason, you shouldn't be charged. You should, in my opinion, not be charged for the transfer. But I can't answer for the way other programs function. I'm sorry.
That's totally fine. Okay, it says, I am pregnant with triplets through IVF and my weight is 43 kilograms. Is it safe for me?
Triplets are not safe. One baby, safe. Two babies, less safe. The more babies you carry, the greater the risk. And if they are triplets, there is a real problem. Premature delivery is a real issue. And if a baby is born too soon, its organs and its function, especially the brain, haven't developed properly enough for it to be able to progress and develop normally, healthily after birth. There are many more problems that occur with higher order multiple pregnancies defined as triplets or greater. I think it's safe to say that women carrying triplets are at far greater risk of miscarriage, at far greater risk of pregnancy-induced complications such as high blood pressure, bleeding that can all be catastrophic and dangerous, and far less likely to deliver the baby at term. Usually pregnancies with triplets will come 7 to 10 weeks early, and when a baby's born that early, usually it's not quite ready to adapt to the outside world and needs assistance. That assistance, although it's improved year by year and is quite magnificent, isn't anything as good as the environment the baby could have by having incubated longer in the uterus. So I don't know why you have triplets. I hope it's not because somebody transferred 3 embryos into your uterus. To me, that is not, in this day and age, an advisable approach.
Okay, I have another question that's kind of similar to what you just mentioned there. It says, should I do the insert with 2 twins, or should I do an insert with twins, or is one fine for me? I have fibroid endometriosis.
I would definitely put in 1 embryo at a time. And if you've got endometriosis, remember, there's a 1 in 3 chance you could have an immunologic implantation problem, which prevents the embryo from attaching, and that should be evaluated thoroughly. Cannot be done by doing blood tests in a regular local laboratory. It's got to go to one of 3 or 4 reference laboratories that are reproductive immunology reference laboratories in the country. Read the books that I'm making available to you. It'll explain that. So again, terribly important to check out and make sure that there are no problems with implantation or problems with the embryos.
That other question that we didn't know the wordage of, she said 3 months before the egg freezing with endometriosis. So the original question was, do you have any recommendations on what to do 3 months out from a second egg freezing at 36? The translation is 3 months before the egg's freezing with endometriosis.
Again, the endometriosis is the question. If you've frozen eggs and the protocol used for ovarian stimulation didn't prejudice them during their stimulation, and you make embryos and the embryos end up being PGTA normal, chromosomally normal, then the issues of implantation. And I've pointed out on several occasions, and it's also in both the books that are available to you. If you comment Sher at the most recent video, we will send you free copies, downloadable ebooks on those books. But you'll find chapters on endometriosis, which will point out that 1 out of 3 women who have endometriosis, regardless of how severe it is, will have an underlying immunologic problem that could compromise the ability of the embryo to attach. You need to identify, quantify, and typify the problem and address it before doing the transfer.
Okay, let's go to another. We have a lot coming through. If we don't get to your questions today, guys, please go leave it on the Instagram or the most recent TikTok video, and we'll make it into its own video or answer you through DM. All right, let's see. We answered that one. After chemical pregnancy, can you get pregnant right after?
You can get pregnant, but I always recommend that after a very early loss, be it a chemical pregnancy or an early miscarriage, give yourself a full month break where you do nothing and wait for a normal period to occur before you try again.
Is it true that in a day ovulation, if you do intercourse, conceive... No, I don't know how to conceive a boy 5 days before a girl. I don't know what they're asking.
You want me to look at it?
No, it just doesn't even make sense the way it's worded. So I'm gonna,
okay.
Some people say you're more fertile right after chemica. Is that true?
After chemical pregnancy?
I think that's what they meant to say.
No, that is not correct. You're not more fertile. And again, it's better to wait a month, give your ovaries a chance to recover before you try again. You're not more fertile after a chemical pregnancy.
We had a question similar to this, but this is a new person in the live stream here. It says, at 16 weeks, can I breathe yet or still panic for miscarriages and other things?
If you've reached 16 weeks, unless you've got a really significant mechanical problem in the uterus that weakens the neck and makes it more likely that the pregnancy could drop out, could suddenly be lost as a miscarriage later on, you're probably free and clear. 16 weeks is a pretty good position to be in, means that most of the factors that will impact on the ability to maintain the pregnancy have been passed, and you're in the clear most of these cases. That doesn't mean that it's impossible to have other problems that are genetic or infective or weakening of the neck of the cervix, known as cervical incompetence, creep in.
Is it possible to get euploids or euploids at age 42?
The question is it possible at age 42 to still get euploid embryos? The answer is absolutely yes. Remember what I said earlier on. As a woman gets older, the eggs that have been in her ovaries all her life go through a wear and tear process. Under the age of 35, 2 in 3 or 3 in 4 eggs will be normal. And they will determine, in most cases, whether the embryo is going to be euploid, provided you used an individualized and strategic protocol for stimulation. So, yes, as you get to 40, only 1 in 6 is going to be normal. At 42, roughly about 1 in 10 eggs will be normal. So 9 out of 10 times, 9 out of 10 eggs are not going to be normal. But if the egg is normal when you harvest it, and you fertilize it and makes a euploid, PGTA normal embryo, in my opinion, that embryo has got almost the same chance of resulting in a viable pregnancy as if the woman had conceived 10, 15 years earlier. So getting to a normal, chromosomally normal embryo and placing it in a receptive uterus, again, good seed, good soil, is what it's about. So what we often do in women who are older, because they are much more at risk of having abnormal egg development, even in having an abnormal hormonal environment in the ovary during stimulation, is it's critical. Nothing is more important than implementing a strategic and individualized approach to ovarian stimulation that won't compromise the egg during its development and lead to an aneuploid embryo. You cannot save an embryo that starts from an egg preordained because of age to be abnormal. But if the egg went into the cycle normal and you don't use an individualized protocol, you will compromise even the ones that had a chance from being normal. And so what you do at 42, in my opinion, is you go through IVF, get your eggs, fertilize them, do PGT on the blastocysts, and then bank those that are good. And maybe repeat the cycle over and over again to bank up and store more embryos, because the freezing process we use today does not necessarily in any way prejudice the ability of the embryo to propagate a viable pregnancy. So if you bank them, you're making hay while the sun shines, and you can then come back later, because if you wait, you could end up having fewer eggs a year later and not have the same opportunity.
We're going to go with this one first here. Is it possible that a miscarriage can be caused by a hotness in the stomach or heat?
I doubt it. I doubt that heat on the abdomen or being exposed to hot tubs and excessive environmental heat is going to affect the ability of the pregnancy to survive.
How do you know if you need an immune protocol for a frozen embryo transfer?
So the question is, how do you know if you need an immune protocol? Remember, immunologic factors are one of 3 major factors that affect the ability of the embryo to attach. So if a woman has got predisposing factors towards an implantation problem, you have to look into it. And that is women that have had repeated miscarriages, women that have unexplained repeated IVF failures, in spite of putting good quality embryos that are chromosomally tested and normal into the uterus, women that have got underlying autoimmune diseases in themselves or in their families, lupus, rheumatoid arthritis, hypothyroidism, scleroderma, celiac disease, MS, and even endometriosis. which many of us, including myself, believe has an autoimmune underpinning. In those situations, there are often, in a third to a half of cases, immunologic problems that need to be addressed, but they can be well approached and dealt with. So yes, there is definitely an approach that you've got to take in cases such as that.
What age is your max for an IVF patient that you guys will take?
The big problem with age is two things. One, the older the woman gets, the less likely it is she can make good eggs. So when she's over the age of 40 and definitely over the age of 44, she ideally needs donor eggs. Now, is it possible to have a baby with your own eggs after that age? Yes. In my opinion, and I could be wrong, the oldest woman that I'm aware of that's ever had a baby with her own eggs was 48 when she gave birth to the child. I know her because she was my patient. I did everything in my power to dissuade her from trying with her own eggs because the chances are so small. But she was adamant, and she has a right to be right. She has a right to be wrong, and I don't have a right to be obstructive against her wishes. So we went ahead and did 6 IVFs on her. Believe it or not, she had pregnancy, she had a baby, and that child is my godchild today. So I really want you to know it can happen. Is it likely to happen? No. Is it wise to try with your own eggs over 44? No. The other factor depends upon ovarian reserve, which tells you by your AMH how many eggs you're likely to have left. And that's another factor that plays a role. What age is it possible to have a baby if you use donor eggs? As long as you have a normal uterus and you're healthy enough to carry a baby, that can be determined by individualized testing, looking for factors that could lead to pregnancy-induced complications. You can get pregnant. My oldest patient ever to have had a baby was 58, and she had twins, and she had twins with donor eggs. Whenever you hear of women over 50 having had babies through IVF, and they try to imply that it's with their own eggs, don't believe them. Almost all of these have used donor eggs. So just a little bit of caution there.
Okay, we'll answer a few more here. How many egg retrievals do you recommend per lifetime? When is it a good time to stop, if at all?
Egg retrieval, if done correctly and using the appropriate protocols, shouldn't prejudice your physical well-being. The time to stop is when there doesn't seem to be, despite everything you do, a chance of there being a success. And that is usually means that you then need to move on to IVF with an egg donor and sometimes even a gestational carrier. But I don't think the number of egg retrievals you've had matters that much. I have a patient who I was giving a lecture in Monash University in Melbourne, Australia some years back. She was a physician. She came to me and she came to the podium afterwards. She was 42 years of age and she had an AMH of 0.1, which means she was imminently menopausal. She had done 24 failed attempts at egg retrieval in the past and had never gotten pregnant. The reason why she had an immunologic problem, aside from her diminished ovarian reserve, and I took blood back from Australia to the United States, we tested it, and yes, she came up positive for what we call activated natural killer cells, meaning she had an immunologic problem preventing the embryos from attaching. She and her husband came to America. We used an individualized protocol. We got 4 eggs out of her. One of them was chromosomally normal or euploid. I transferred her under treatment for the immunologic problem. She gave birth to a child. And so it just goes to show the number of times you try isn't important.
All right, I have another one here. We'll go with some Instagram questions here. What makes someone a better candidate for IUI versus IVF?
Okay, intrauterine insemination is where we take sperm from the man, separate the sperm from the milky fluid in which the sperm is present, and that comprises 98% of the ejaculate, only 2% is sperm. We then process the sperm in the laboratory to enhance its activity, and then load it into a thin catheter and inject it directly into the uterus. Ideally, this should be done in stimulated cycles, When you do it in natural cycles, you aren't really improving chances of success. It should be done in cycles with ovarian stimulation and usually not using oral fertility drugs such as clomiphene or letrozole, but using injectable fertility drugs. Now, I know a bit about this because I'm the person that introduced IUI into the field of medicine back in 1984, and I've written widely on the subject. IUI is a good procedure if the woman's ovulating and has got a problem at the neck of the cervix where the mucus through which the sperm normally must pass to reach the uterus and fertilize the egg is thick or inhospitable. That's the best time for doing IUI. The other one is if you're using donor sperm that was frozen. You can't take frozen donor sperm and inject it intravaginally. It will not be as viable. You have to then spin it down, process it, and inject it into the uterus. The other time IUI is fine is if you want to pinpoint the timing of ovulation, provided the woman's got perfectly normal tubes, and there are relative contraindications to IUI, that you should not do IUI in because the success rate is so low. One of them is endometriosis. The success rate is so low that you're wasting a lot of time doing IUI. You need to go to IVF if you need to do assisted reproduction. The second one is male infertility of moderate or severe nature. If you've got moderately severe or severe male infertility, IUI will not improve the chance of no treatment at all. The third one is in women over 40, where the chance of success is about 1 in 40. No one at that age, especially since many of these women have also got diminished ovarian reserve, have got the time to waste on something that gives them less than a 1 in 40 or 50 chance of success. Those women need IVF. They do not need IUI. And there are other indications as well, but those are the most important and the most important considerations.
All right, we'll do down for one more question here, and then we'll wrap up. Anybody who didn't get their question answered, please comment on the most recent video. We will make it into its own video, or we will DM you or comment the answer to your question.
And just before you get to the last question, let me again say, number one, this is my pleasure doing these live feeds. I can plan on doing it repeatedly every second week. So 2 weeks from now at 2 p.m. West Coast time, we'll be back doing another live feed. Spread the word around to your friends who may be interested. And please come back with additional questions then. If in the meanwhile you have questions, simply comment below the word Sher and type in your question. We'll address them individually. For those of you that would like to talk to me, my patients come from more than 70 different countries. If you want to have my input online, because I do all my consults online, all you need to do is you need to email my assistant, Patty, P-A-T-T-I, at concierge@sherivf.com, concierge@sherivf.com, and tell her you'd like to set up a consultation with me. She will set that up for you, and we will have a chance to talk online. For those of you who simply want to get my literature, my books that I've written with my partner, Dr. Drew Tortoriello, comment the word Sher in the most recent video, and I give you my word, we will send you the books free of charge as free downloadable ebooks by return.
Beautiful. We have a lot of people saying thank you. They appreciate what you do. We have one person that says, I am one of your IVF babies from 1996, and we are considering IUI or IVF next year. Thank you so much for all that you do.
That's great. Thank you.
All right, we're going to finalize this last question here. Hi, is it normal to have only one blastocyst at age 39? I am so disappointed and just don't want to do a fourth or fifth retrieval to have enough eggs.
Again, it is not abnormal if you only make 1 or 2 or 3 eggs, because of the fact that as you get older, your AMH may be going down, and the number of follicles available may be less, and you can make more eggs than the follicles will provide. But the biggest problem is when the wrong protocol is used for ovarian stimulation. If you don't use an individualized approach, and you use recipe approaches, or one-size-fits-all approaches, you'll compromise the eggs that are being prepared for that cycle. And you'll end up with many of them being abnormal because they've been rendered abnormal by the abnormal hormonal environment created through that action. So in those cases, you may end up with eggs that are abnormal and therefore few embryos. And if an embryo does not reach the blastocyst stage, it is almost invariably aneuploid or incompetent. So if you had embryos but they never got to blastocyst, more reason for you to go somewhere where you can have an individualized approach to your ovarian stimulation. And thank you once again. I really appreciate all of you attending these. And I want to also mention while I'm here, I've just written my memoirs. I'm very proud of it. I was the first person in the United States to be present in the IVF private non-university arena, started the 4th IVF program in the country, and have been instrumental, or shall I say influential, in the births of more than 17,000 babies. This memoir of mine tracks my life from a child in a small country town in Africa, all the way to England and through the United States to the present time. And I'm very proud of the memoir. It hasn't come out yet. I've just finished writing it. I'm going to reach a point where I intend to read it as a readable book online for people to listen to. But I really want you to be on the lookout. It's called Life by Design. And if you get the book down the line, you see it, spread the word around, and I'd love for you to read it. Thank you. Bye.
Thank you all for joining. Go comment your questions if we missed them today on the most recent video.